comfortable with that, please say now or forever hold your peace. Okay, welcome everybody to tonight's training session, which Derek has very, very kindly set up for us. So background to this is that we've now been doing the discharge for approximately 2 years, maybe even more than that, where we looked into the opportunity to see what difference we could make through the community pharmacy network around supplying discharge medicines at the point of discharge through the community pharmacy network. And we sense checked that very early doors through a limited pilot, and what we actually proved, and I'm sure Derek will pick up on this, is that we can get patients out of hospitals at least 2 up to 3 hours quicker than sitting in discharge waiting on medicines within the hospital. And when we took when we took feedback from patients on that, it was fantastic. They all wanted to do it. There was heated discussions in wards when one person couldn't access the service, when another person did, because they could see the benefit of getting out quicker rather than being stuck in a hospital. And it also ultimately helps with bed blocking as well and freeing up beds earlier. So it was a combined pilot that in effect had acute colleagues, primary care colleagues and community pharmacy colleagues all working together for the benefit of patients coming out of hospitals. And we're now at the stage of really having to ramp that up and start to get volume of numbers through so that we can really prove the proof of concept of this service. Some of you may or may not know that this is actually part of the Scottish Government's recovery plan coming out of the COVID pandemic, and in effect they have identified this as one of the solutions to helping with ongoing care in communities and putting care into communities out of acute settings. So to say we're under a bit of pressure is probably putting it mildly, because we want to be able to prove that it works in totality. The eyes of every health board in Scotland are watching us, because in effect others have toyed with the idea of doing a pilot and a test of change, whereas we've grasped the nettle and we've run with it. So I'm delighted to introduce Derek, Pamela, Anne, and I see Sarah's on the call as well, as key players within our team who have created this service, who have developed it over the couple of years that it's been running, and really got it to the point now where we've got it where we really need to see patient traction out there around the numbers that we've got coming through. So I would just like to express my thanks to those that I have mentioned there, but in particular Derek, who's done a power of work both in his role from community pharmacy and as a prescribing support pharmacist as well, to get us to where we are. Now, we took feedback from the contractors who have been involved so far, and we took feedback from the Contractors Committee, and we've been working with them closely, and Community Pharmacy Scotland as representatives as well. And we've listened to the feedback we've had, and as a result of that, we're about to change the way that we actually operate the service going forward. And Derek's going to explain all that as he runs through the actual service tonight around what needs to be done, how it's done, etc., etc. And that's all due to the feedback that we've received from the contractors, from the guys that are out there and delivering that service on our behalf. So we've listened, we've changed, we will continue to listen, and we will continue to change until we get it to the point that we feel that it's the best service that we can possibly deliver. I don't really want to say much more, because a lot of it is in the detail, and that's what Derek's going to sort of talk you through tonight. However, what I will say is that, you know, thanks for coming on board. Thanks for the people who have come along tonight to hear the training and hear what the service is all about. And I will thank you in advance of the difference that you will make to patients that you are serving in your communities. Because ultimately, when we get that discharge made, that understanding of the patient's new medication or changes to medication, it's the community pharmacy teams who are going to be working hand in hand with primary teams to make a difference to people where it really matters in their communities with the right care at the right time. So I'm going to shut up now, and I'm going to hand over back to Derek. I wish you every success in the service going forward. Please keep feeding back to us any issues that come up, because we're constantly taking feedback and trying to review and trying to change wherever we possibly can. So thanks to Derek and the team for setting this up tonight. And as I said, best of luck as we move forward going forward. And Sarah, looking forward to working with you as the new lead in clinical care and acute care and driving that forward from an acute side. So thank you very much, folks, and back to Derek.
Thanks, Alan, very much appreciated. So thank you everyone for joining us. What I'll do is, without much further ado, I will get a nice presentation that goes through the kind of nitty gritty of the service. So I'll make that face that everybody makes as they attempt to share their screen. 2 seconds.
And then the immortal words, can you see it yet?
Can you see it yet? So hopefully, if somebody can tell me if you can see that, that'd be ideal.
Yep. That's it, Derek. It's up. Yep.
So unfortunately, when presenting, I can't see anybody's faces, which is a bit of upsetting. So any questions, please feel free to either shout out or if you want to keep them to the end, it's up to yourself as well. So first of all, my name is Derek Jameson. So I'm a community pharmacist for Lloyd's Pharmacy. I'm based in Abercrombie Street down the Calton. I'm also seconded 2 days a week into primary care as a prescribing support pharmacist. So I've got a wee bit of a foot in both camps. So the main aim of tonight, the main aim is to provide the training for the community pharmacy teams on the process required for the MedRec service. I very purposely put community pharmacy teams. All of this is designed to be carried out by either the pharmacist or a pharmacy technician with access
Derek,
to the portal.
don't know, you were not seeing the slideshow, we're just seeing slides.
Wait a minute.
I think it is your first slide we're seeing, but
okay, give me a second. Let's try something else. Is that better now?
That's it. Thank you.
Okay. So as I was saying, thank you, Pamela. The service is designed to be carried out by either the pharmacist or the pharmacy tech. To be honest with you, my instinct is that I really feel this is a real service where our technician population in community pharmacy can really grasp a hold of and add real benefit to it. When we do a lot of the medicines reconciliation of immediate discharge letters in primary care, our technician population do it and they're absolutely excellent at it. So I think this can be a real service where our community pharmacy technicians can run with it. All the information that I'm going to be talking about tonight is available online. Clinical portal access, so not just for this service, but for community pharmacy in general, clinical portal access is absolutely vital for us just now. So it can be any technician, registered tech or pharmacist, so any of us and all of us should have it. The link there is on the website, gets you the form to fill out to submit into the community pharmacy development team. Strongly encourage all the pharmacists, all your technicians, anyone can get access to it. And just a wee note, some of the examples in the presentation will not look completely right. The patient I've been using is a test patient. So within Clinical Portal, patient with a CHI number of all the threes is a test patient. That can actually be used by anyone. So quite good for if you're new to Clinical Portal and you just want to see what it looks like, but not going into a real live patient. That CHI of all the threes gives you a test patient that you can look at. So into the nitty gritty. So what I'm going to do is I'll talk through step by step what the process looks like. Again, all this is available. There'll be a recording of this online and all the step-by-step guide is online, but if you're anything like me, I quite like a kind of presentation of something. So what happens first of all is you'll get a phone call from the hospital, and the hospital will give you the name of a patient who's about to be discharged through the MedRec service. That's all the information that the hospital will give you. They won't give us any information on new or changed medications or anything like that. They will just give you the patient's name and their CHI number and tell you that they're being discharged and can you provide discharge medications through the CP MedRec project. What I've designed a form that we can use to fill out that will refer to a lot throughout this guidance. So that's a wee picture of it there. So from the information the hospital given us, we can immediately fill out patient's name and the patient's CHI number. We can also fill out all the patient's current medication, which is this we call here, from the information that you hold on your PMR system. So for this test patient, I have them on aspirin, simvastatin, ramipril, omeprazole. So that's from my own PMR system. To complete the MedRec, we need to log into Clinical Portal. So the link there is the link to Clinical Portal, and enter your username and password. To search for the patient, what we do is we go into search, click on the bit that says patient, and select discharge prescription. And we put patient's CHI in there. When we hit the search button, we get a screen up that looks like this, and you just then click on any of the highlighted area to go into the patient. That'll then bring up a screen that will look like this. So to find the immediate discharge letter, where we look is under correspondence, we open that wee tab and select immediate discharge letter. The one that you'll be looking for will be at the top, and it's always worth double checking that the date on it is today's date. So again, that patient is being discharged today, so it'll be today's date. From that IDL, from that immediate discharge letter, we can then complete the hospital ward, admission date, and the discharge date on the CP MedRec form. So hospital ward, admission date, and discharge date. Then use the information on the IDL to complete the discharge medication section. So here on this example we've looked at, our patient has still on aspirin. The simvastatin's not on the IDL, it's been stopped. The ramipril is now 5 milligrams twice daily. Omeprazole 20 is 1 twice daily. And they've got a fixed course of trimethoprim, probably for a urinary tract infection, and a newly commenced atorvastatin, 80 milligrams. A couple of wee things to note. So there's been some changes since the inception of the project. Within the hospital setting, we've got a new computer system called HEPMA that's integrated into the Orion, which they use for discharges. It's all very fancy. The main things that we need to know from it is sometimes the doses will be quite strange looking on it. So because Orion takes the information out of HEPMA, HEPMA has very specific dose timings on it. So we can see here that in this example, the apixaban is 5 milligrams twice daily at 7 a.m. and 10 p.m. That's because that's the times that they're giving it in the hospital. That doesn't necessarily mean that it has to be given at those times. So again, twice daily, morning and night. And again, the cyclazine 3 times a day, showing at 7, 12 and 10 when required for nausea. Again, that specific timing isn't overly important, it's just where it comes out the system. Exceptions to this are things that we're all aware of, like the Parkinson's meds, where there is kind of a set time schedule to it. So if we see a difference when we're doing the MedRec that the apixaban now says at these specific times, that's just because that's the times it was given in the hospital. Also, at the import stage of it, HEPMA overwrites all the existing and historical medications. So we'll see a lot of things like this that says superseded by HEPMA medication and superseded by HEPMA medication. That doesn't necessarily mean that the medication's been stopped. If it still appears in the active medication list, it can be continued as recommended. Basically what that is a simple way of looking at it is it's for the system to put the new data on, it's got to overwrite all the old data that was there. And then for it to do that, it has to show this superseded part. So the important part for us is what's still in the active medication list. So once we've done our medicines reconciliation, so we've taken that form and we've wrote on it what was on our PMR system, and we've wrote on it what the patient is now on, and we've looked and seen where the differences are. What we now need to do is to create an S-bar for the patient. We're using the S-bar as a communication tool, and that can be found within the PCR. So if you log on to your primary care record in the pharmacy, you can go into the patient and your PCR and go into the part here to create an S-bar. If for any reason your PCR is unavailable, I know PCR sometimes goes down from time to time, on the website there's going to be a blank copy of an S-bar that you can use as well. I quite like the PCR because it keeps a copy of the S-bar in there for you for future reference, but that's where that lives. Once we've completed the S-bar within the PCR, what we then need to do is save a copy of it and email it to whatever the pharmacy hub is in primary care for your locality. So in the North East Glasgow, that's their email address. In Eastern Bartonshire, that's their email address. And in the Northwest, that's their email address. I need to really emphasise how vitally important the S-bar is. So we have to complete this within 24 hours of the patient's discharge from hospital. This S-bar is what we're going to be eventually using in primary care to update the patient's medication records in the GP practice. And it's those medication records in the GP practice that actually inform what goes on a patient's emergency care summary. So if that emergency care summary isn't up to date, there's a risk that if that patient was taken into hospital in an acute emergency and they pull the information from that emergency care summary, there could be outdated and inaccurate drug information on it. So the S-bar really is a vital step in the process. The S-bar must also include the information that the community pharmacy will complete a new medicines review with the patient within 5 days. So I'll cover a wee bit more information on that in step 11. And the S-bar must include the information on the patient's GP practice. If that's not there, then the primary care teams will send it back to you to get that information. In the training pack and documents, I've included an example of what the S-bar should look like. So we're not looking for War and Peace on an S-bar. S-bar in essence should be a quite short part of it. So the community pharmacy information will all be automatically generated if you do it through PCR, and the patient details will all be automatically generated if you do it through PCR. Bits that we need to add in, apologies, is who we're sending it to. So we're sending it to the prescribing support team and who the patient's doctor is. So doctor, whoever, and whatever that surgery is. A wee quick summary of the situation. So the patient was discharged from hospital, the GRI from Ward 5, a wee bit of the background. So the patient was admitted to hospital via A&E with chest pain and shortness of breath. A wee bit of assessment. So the hospital patient was discharged on the 24th of the 7th. Impression was a stroke negative chest pain. And then the real important part is the recommendation. So new medication started. So well, we've done our med rep. We know atorvastatin 80 milligrams was started. Those who want to be taken tonight, and we are going to supply them with 28 of them. They're also asked for a short course of trimethoprim, 1 tablet twice a day from the 24th to 7th. We know that was the same day as they were getting discharged, so we'll give them the full supply of that. We'll give them the 3-day course. And the ramipril dose has been increased. So again, we chose to give them a 56-day supply. And the simvastatin, 20 milligrams have been stopped. One of the questions I always get is how many of everything do we supply as part of this project? And it's free for the pharmacist to decide what that should be. So you guys know these patients best. So if this was Mrs. Smith, it was going to my pharmacy and I regularly do Mrs. Smith's medication, I would know, Mrs. Smith's actually due her repeat medication in 2 weeks' time. What I'll do is I'll give her 2 weeks of all this medication so that when she gets her new lot on prescription from the doctors, it will sync up with it. Exceptions to that are where there is kind of short fixed courses of things, we then can just supply for that short fixed course. So we're trying to incorporate a wee bit of stopping medicines waste as well. So that the risk always is if we give them a full month or 2 month supply, whatever of it, and then they get a repeat prescription in a month's time from the GP. So we know these patients best. We know where they are on their medication cycles usually, so it's quite natural for us to make these decisions. So how do we claim for the medication? So this is one of the new parts of the service. So previously we had quite a complicated claim form process that we had to go through. We've managed to, with agreement of the contractors committee, simplify that quite a lot. And we now just complete a UCF to claim for the quantities of each of the medications that we've supplied. So we should only be supplying any new or changed medications, any medications that the patient was previously on before they went into hospital. They should have a supply of them at home, so only new or changed medications. Do it through a UCF and we'll get paid for the drug cost electronically through the usual UCF payment mechanisms. Within 5 days of the patient's discharge from hospital, we have to contact the patient and complete a new medicines intervention with the patient. So this can be done either face-to-face, via phone, or via NHS Near to Me if available. So this comes directly from Health Improvement Scotland's best practice guidance on medicines reconciliation. Basically what this is a chat with the patient to understand, to make sure that they understand what medication has changed while they're in hospital. Being in hospital is a really difficult process, as I'm sure we can all understand, for the patients. They get a lot of information thrown at them, especially an example like this one where the patient's had a heart attack or a stroke. They'll see a lot of specialists, they'll get told a lot of different information, and it's really important for us to just have that conversation with them about, okay, what's happened with your medication? This has been started, why has it been started? What's it used for? This one's been stopped, why has it been stopped? It's relatively simple, straightforward stuff, but the benefit to that patient of understanding their medication, especially in places like post-MI where that new medication can be quite a few changes for them. So the new medication intervention tool on the PCR is a really good tool that helps us to have those conversations. The final part is we get a service fee per patient of £35 per patient that we do through the service. To claim that, there's a claim form that we submit to the Community Pharmacy Development team at the end of the month. That claim form will be available on the website, on the Community Pharmacy Development page on the website that I'll send a link around to everyone. End of the month, we just fill that in and submit it, and we'll get the payment for that through them. Discrepancies. So sometimes the medicines reconciliation is very straightforward and simple. Other times that we'd look at it and there might be some questions around it. So I've tried to kind of cover a wee way of kind of helping with that. So medications, the questions, sorry, it might be including but not limited to some things you might not have in your PMR system. So if the patient's had a course of antibiotics recently and they've taken it to another pharmacy, you might not have that on your system. Or where there's been an incomplete medicines reconciliation at the hospital end, or occasionally where there's transcription errors on the IDL. So sometimes in the hospital IDL, they'll put omeprazole tablets instead of omeprazole capsules. So medicines IDL tab on clinical portal can be used to help us and attempt to resolve these discrepancies. And I will show you on the next page how to access that. So within clinical portal, so on that one that we looked at earlier that had the example where it said clinical documents, and that was all listed down here. And that menu bar along the top, there's a tab called medication stroke IDL. If you click on that, you'll get a screen that opens that looks like this. And what we then want to do is click on the button that says list history. What will then take us to is a screen that will look quite complicated like this. But the main things that we see on the screen are the discharge one, which has always got this wee pin in it. And we then want to select admission review. What we're now looking at then is that brings us up this, and that shows us a list of the medication that the patient was on when they went into hospital and the medication that they're now on when they've been discharged from hospital. And it shows us quite clearly if something has been stopped, if something has been added. What we can also do is from within that, when you click on one of the medications, so in essence, you would click on that Ramipril, you just click on it there. What happens is it would open up a nice page like this. It shows us just that Ramipril. If you then click on the wee button that says show, it will then give us some more information. So it might say in that been discontinued, is no longer required, or blood pressure change or whatever. So it's a wee extra way always looking at that. Support. So we've tried to build in as much support as we can, because we know that doing medicines reconciliation in a structured way like this is something a bit different for us in community pharmacy. I forever say that it's not actually. We actually do a lot of medicines reconciliation already in the pharmacy. We just don't document it. I'm sure all you guys are the same as me. When you get a change to a dosage box patient in the hospital, you go in and you have a look at that IDL, or you look at the IDL that they hand in and see, right, what's different from that from their dosage box. That's medicines reconciliation. This is just a way of doing it that's a bit more formal and has a form attached to it. So if we're still unable to resolve any of the medicines reconciliation queries, then Sarah and the team in the hospital have been very kind to give us 2 contact numbers, 2 mobile numbers that we can phone to ask some questions. And for any other non-clinical operational issues, so if it's just about how do I do it, or where do the forms live, or we're not sure how we're doing with that, then your pharmacy champion is the first port of call. So on the full guidance, the phone numbers there for the community pharmacies, and this for the community pharmacies champion, sorry. And this I've just included the email addresses. So for the Northeast, that's myself and Hannah. From Northwest, it's Gary and Stuart. For East Dun, we don't currently have a champion at the moment that I'm aware of, so I'm quite happy for any emails or phone calls to come my way. If you've got any issues with relation to the claim form or for the payment side of it, then GGC CP Dev team are the people to contact for that. So it's a bit of a whistle-stop tour. I will stop sharing my screen and see if anyone has any questions, or if any of our other guests would like to add anything.
I think everyone's being awfully shy, Derek.
Oh, that's absolutely fine. And just to put Anna on the spot, I'm going to ask Anna if she would like to say a few words as well. So Anna is our, I'll let Anna introduce herself because I don't know her full job title now.
You're on mute, Anne.
Can you hear me now? Yeah, sorry, I've got this integrated monitor and it goes to sleep every so often, I think, if I don't speak often enough. So yeah, so my name's Anne Thompson. I'm the lead pharmacist for clinical services in primary care. So work across the 6 HSCPs we've got with the teams there around the services that we deliver in and around general practice and care homes in terms of the setting. So I have been working really closely with the project team, including Derek, Pamela, and now Sarah, who's on the call. We also have a project manager helping support us, and we did have previous support from Nick Cassidy, who's now working at the Golden Jubilee. So I guess all I was going to say in terms of, I think that's really helpful overview, Derek. It's really helpful to see the step-by-step process. I guess there's still bits of this project that we're still working on in terms of improvement. So I think the vision we would have for this service really is that eventually we have a single medication record, and when you reconcile and review, you can update the record yourself. We've just got a bit of clunkiness just now because only our teams can access the GP record, and that is the single source of medication truth at the moment, that we do need this kind of loop closed once you've done the reconciliation so that we can update the record. Because you are doing a professional reconciliation, though, it does mean we can use different types of staff, like our support staff, to help update that record. So it still has an advantage to us back in the primary care setting. The other thing we've been working on with eHealth is to see if we can get a better way of notifying the community pharmacy that the patient is actually in hospital and when they're discharged again, particularly for priority patients. That is quite clunky to do because we've only got certain systems we can work around just now. But again, our intent is to try and make things as easy as possible for us to talk to each other across the systems and sectors, and for you to know what's happening with your patient as seamlessly as possible, using electronic communication where we can. So we're still not quite there with all that kind of side of things because we're kind of, as I said, a bit stuck with what we've got. But our intent is to continue to work with eHealth around that, particularly as other opportunities come in, like there's a new GP system being re-provisioned, and our GP practice will start to move towards that later this year. So there are opportunities to look at some of that technology enabler as well. But it's been a great project to work on. I think it's helped strengthen how we work, particularly with our acute colleagues around some of this. And I guess the intent at the start of this was for us to look at how we work better across pathways of care rather than sectors of care, and don't duplicate what each other are doing. And if, as I said, you've done a professional reconciliation in community pharmacy, then why would we do it again in primary care again? And hopefully, as I said, the systems over time will allow us to do that kind of stuff more easily and prevent that duplication and make sure the right stuff is done in the right place where patients need it at the right time. So thanks, Derek, for your presentation and for continuing to champion this work and help us bridge the divide, I guess, between the different sectors. And if anything, it's just given us enthusiasm to work on other aspects of work around things like medication review and think about how we can build on some of this work as well. So yeah, community pharmacy are key to all of this. We don't have enough workforce in anywhere else to do all of it, so we need to do what we can in the best way. So thank you for participating in this project. That was more than a few words, sorry, Derek. Or
no,
if you were just looking for me to just myself, then I went beyond that, so apologies.
No, it's absolutely fine. I just wanted to echo, like, one of the things that I'm really passionate about, and especially through this project, is I feel that pharmacy, when we work together as a whole team, we can make such a huge difference to patient care. Community pharmacy we have that relationship with Mrs. Smith. I know Mrs. Smith. I know Mrs. Smith's family. I know what she's on. My dispensers will be able to tell me what's in Mrs. Smith's dossett box without even thinking about it. That relationship is so key, and where pharmacy can stop being defined by the name of the setting that they work in and just be a whole team of pharmacy. And this does that. This allows us to be hospital pharmacy and community pharmacy didn't really have many pathways where there was an opportunity to speak to each other. This has opened that up a wee bit and getting some primary care involvement in it as well. And I think that there's a real, certainly, drive on my behalf that I would love to see pharmacy just become defined as pharmacy and not by the building that we work in. So I'll get off my moral high horse now and let Pamela say a few words, and then we can let people go.
I was just going to mention the PGD. So obviously the supplies are made utilising the PGD, which I know most Boots stores have. Somebody within each Boots store has now signed. So if you are working in a pharmacy that nobody has signed the PGD yet, could you please find that and get that sent in? Just to complicate matters slightly, that PGD is being replaced with a longer authorised version, but the PGD itself has not changed at all. The content of the PGD is exactly the same. It's only the expiry date that's changed. So that's going to start coming out as of Monday. So if you see it and you think, Jings, I've just signed one, why do I need to sign it again? It's really just to extend the expiry date. So again, if you see that, please again complete it and send it in. And it works in the same way as the unscheduled care PGD, and that's how that's your legal authority to supply the medicines against the IDL on Clinical Portal, just in case anyone was wondering. And I think that was all I was going to say, Derek.
Lovely. Thank you, Pamela. Just on that note, what I'm going to actually do is share my screen again.
While you're doing that, I should say, sorry, I don't think I said, but Gwen Shaw is my equivalent in hospital, and we've been working really closely on this as well, and it's really helped us kind of start thinking, working differently. So apologies, I meant to give a shout out to Gwen earlier, who's away enjoying herself in France this week. So
I'm sure Gwen will forgive you, Anne. Just for all our community pharmacy colleagues, a really good tip for you that I'm sure you'll probably be aware of, but it's always worth sharing anyway. So if you just Google communitypharmacyscotland.nhs, the very first link that comes up, if you click on the NHS Greater Glasgow and Clyde part of it, what this gives you is absolutely everything, all the services that are provided in Greater Glasgow and Clyde, and where all the forms and things are for them. The really important ones for this service are the clinical portal one. So that gives you where the link is to actually get into clinical portal, and the forms that are required for you to sign to get access to clinical portal for any pharmacist or any technician. And the other really important one for me is here under Medicines Reconciliation and Supply Project. If you click into that, that gives you, will update the recording, so it'll be the recording of tonight, and it'll also give you a step-by-step guide how to do it, the work form template, a flow chart on it, some guides to clinical portal and PCR, an example SBAR, and a checklist as well. So really good information on that webpage, not just for this service, but also for just about any service that we do in Glasgow. So a really good website just to bookmark. And that's me. If nobody's got any other questions, then we can close up and I can go and have a cup of tea before the football starts.
Well, I think we will just draw this meeting to a close then, Derek, if that's okay. I'm going to now just stop recording.